Hello, Janet Pope here reporting at Room Now. This is lovely Chicago at ACR 2025. I wanted to talk about a nice talk that I heard on the heartbreak. There's a little heartbreak in quotes here of sarcoidosis. So there was a big Stanford cohort of sarcoidosis, and they wanted to look at what's happening in cardiac sarcoid, how is the treatment algorithm, and how do you work these people up and follow them. So in this cohort, as many as 15% of patients with sarcoidosis had cardiac involvement. That's probably higher than many cohorts because they enrich for this area of expertise. They had a really good algorithm, usually PET scan, not usually a cardiac biopsy. They've also had improved mortality with cardiac sarcoid. So the first thing to note is that you will start, if you have active PET scan, cardiac involvement with sarcoidosis. Often you'll have involvement systemically as well, but not always. Hilar lymphadenopathy, etc. Mediastinal nodes too. What you'll find is that 1/3 of patients will respond well who have cardiac sarcoid to methotrexate and glucocorticoids. Then when you taper the glucocorticoids, you want to find out are they going to rebound or not. So they usually do a repeat PET scan to see if it's active. If there's a failure or you can't get the person off glucocorticoids or still smoldering, they'll use monoclonal antibody TNF. They'll usually use infliximab, but they might use adalimumab. Usually, again, there's a very high response rate. If this doesn't work, anecdotally, data are emerging using a JAK inhibitor, so they might use a JAK inhibitor. Why am I telling you about this? I think number one, we have to identify cardiac sarcoid in a patient with sarcoidosis. Number two, there are some risk factors of people who don't respond as well. Often right heart involvement is less responsive, and also people with a lot of systemic involvement are less responsive. Number three, there was an excellent algorithm, and I will take this home. I run a bit of a cardiac sarcoid clinic in order to get access for the drugs for my colleagues. And the final thing is mortality has improved by treating earlier identification, these advanced therapies, and I think also by implantable ICDs because many of these patients die of arrhythmias. Please follow me at Room Now. It's at Janet Bird Dope. Thank you. Bye.